hypertension in special situations. And that will be by Dr. Asaad Akbar Khan. He's also an interventional cardiologist from Shifa International Hospital, Islamabad. And the third talk will be on resistant hypertension diagnosis and treatment by Dr. Tayyab Mohyuddin, also an interventional cardiologist from DHA Hospital, Lahore. But before inviting them to the talk, I would like to display a very common scenario in front of you people, which relates to these talks. And at the end of the session, we're going to discuss about how to address, how to manage such kind of patient. So first scenario, a very common one, a 40 years smoker, male with no known comorbids, does his lipid profile by himself, total cholesterol 215, LDL 135, TGs 200, HDL 42. After having few increased blood pressure reading up to 160/92, and he's consulting you and what to do next. And I think you'll try to get the answer from the talk which I am handing over to Dr. Sohail. I'm stopped sharing my slide. Now the whole proceeding is to Sohail Khan. Yes, Sohail.
Can you guys see my slides here?
Yeah.
All right, so let me go to the slideshow. Thank you so much, Dr. Fawad, for your kind invitation. It's such a pleasure to be here. It's a much needed webinar. All three of us, or all four of us, are interventional cardiologists, and we tend to focus more on PCI and stent, but we should always go back to the basic, and the basic is the hypertension is one of the major factors for cardiovascular morbidity and mortality. It is throughout the world, there are about 10 to 15 million people who die from hypertension every year. And if you look at the numbers, about 1.2 to 1.5 billion with a B, they are suffering from hypertension in the world. But we have seen this this trend of this major prevalence of this disease now is in the low to middle income countries compared to higher income countries. For example, in India, Pakistan, and Bangladesh, about 70% of that 1.5 billion people are living in low to middle income countries. And there are many factors for that disparity: lack of awareness, lack of treatment, and also the lack of that there is some confusion, ambiguity when it comes to diagnosis of hypertension. There are many guidelines. So what I will do in this talk, again, it's only 7 minutes talk. I really don't want to go into a lot of trials, but if you look at the International Society of Hypertension, the way they define hypertension is that the hypertension is diagnosed when a person's systolic blood pressure in the office or clinic is more than 140 and diastolic is more than 90. But again, this is not as simple as it sounds here. Let me just, if his screen is here. So if you look at the classification based on that International Society of Hypertension, the optimal blood pressure is defined if it is less than 130 systolic, diastolic less than 85. High normal blood pressure 130 to 139 and 85 to 89. Grade 1 is 140 to 159 and 90 to 99. And grade 2 hypertension more than 160 and diastolic more than 100. And if you compare this to ACC/AHA guideline, they are a little more aggressive when it comes to hypertension control. They call normal as less than systolic 120 and diastolic less than 80. And elevated is 120 to 129, diastolic less than 80. And stage 1 hypertension 130 to 139 and diastolic 80 to 89. So there is some confusion there. So what I will do is again focus more on the International Society of Hypertension. That's what is normally followed in our country here. So criteria for diagnosis of hypertension based on different setting. In the office, blood pressure, if it is more than 140 systolic, more than 90 diastolic, that is considered hypertension. At home, the home-based blood pressure measurement, more than 135 systolic and more than 85 systolic. And if you look at ambulatory blood pressure measurement, the average 24 hours more than 130, diastolic more than 80. Daytime average more than 135 and 85, and nighttime average more than 120 and more than 70. So again, there is a difference in hypertension definition based on where you measure it. So let's focus on the office blood pressure diagnosis and what should we do and how it should be done. So the condition, it should be measured in a quiet room with comfortable room temperature. Before measurement, avoid smoking, caffeine, and exercise for 30 minutes. Empty bladder, remain seated and relax for 3 to 5 minutes. Neither patient nor staff should talk before, during, and between measurements. Position, sitting, arm resting on table with mid-arm at heart level, back supported on chair, legs uncrossed and feet flat on floor, and device validated electronic upper arm cuff devices. Again, the size of the cuff size is very important. It should be according to individual arm circumference. If you have a smaller cuff, that might overestimate blood pressure, and larger cuff may underestimate blood pressure. Again, it's a very important point. Protocol: at each visit, take 3 measurements with 1 minute between them. Calculate the average of the last 2 measurements. If blood pressure of first reading is less than 130 by 85, no further measurement is required. Interpretation: blood pressure of 2 to 3 office visit, at least 1 to 4 weeks apart, more than 140, 90 indicates hypertension. Again, the diagnosis should not be just based on one measurement or one setting. Again, this is what I just talked about, the appropriate position and cuff sizes and the back support. And the measure blood pressure in both arms, preferably simultaneously. If there is a consistent difference between arm more than 10 millimeter of mercury in repeated measurement, use the arm with the higher blood pressure. If the difference is more than 20, consider further investigation because that might indicate subclavian stenosis. The office blood pressure measurement, if it is less than 130, 85, remeasure within 3 years or 1 year if the patient has other risk factors. If it is 130 to 159 systolic or diastolic is 85 to 99, if possible, confirm with out-of-office blood pressure measurement. High possibility of white coat or mask hypertension in those patients. Alternatively, confirm with repeated office visit. If it is more than 160 by 100, confirm within a few days or weeks. Now let's focus on out-of-office blood pressure measurement. Out-of-office blood pressure measurement, either by home blood pressure monitoring or 24-hour ambulatory blood pressure monitoring, are more reproducible than the office measurement, more closely associated with hypertension-induced organ damage and the risk of cardiovascular events, and identify the white coat and mass hypertension phenomena. Out-of-office blood pressure measurement is often necessary for the accurate diagnosis of hypertension and for treatment decisions. In untreated or treated subjects with office blood pressure classified as high normal blood pressure of grade 1 hypertension, which is systolic 130 to 159, diastolic 85 to 99, the blood pressure level needs to be confirmed using home or ambulatory blood pressure monitoring. So again, whenever you have this borderline blood pressure measurement in the office, it's always good to confirm that with a home-based monitoring. Again, this is a little busy blurred slide, but when it comes to home-based blood pressure monitoring, the measurement protocol before each visit to the health professional, 3 to 7 days monitoring in the morning before drug intake if treated, and the evening. 2 measurements on each occasion after 5 minutes sitting at rest and 1 minute between measurements, and long-term follow-up of treated hypertension, 1 to 2 measurements per week or month. And then for 24-hour ambulatory measurement is 24-hour ambulatory monitoring at 15 to 30 minutes interval during daytime and nighttime. At least 20 valid daytime and 7 nighttime blood pressure readings are required. If less, the test should be repeated. So in summary, hypertension remains the major cause of cardiovascular morbidity and mortality. The deaths due to hypertension are preventable, and we can really help our patient to live healthier and longer. Thank you so much.
Thank you, Sohail, for covering nicely the subject within allocated time. It's not easy to cover things in 7 to 10 minutes, but actually, really, you have highlighted the point. It's not just number game. You have to identify a real baseline blood pressure reading to make a clear diagnosis regarding your patients. So you have to take out all the influences out of the patient. Now we are moving on to the second talk, and I'm seeing Dr. Asaad patiently waiting for his turn, and he will be talking another very important subject, that is managing hypertension in special situation. So Asaad, it's over to you.
Sorry, you are mute.
Asaad is ready with his slide, and I think there's something wrong with the voice. So Asaad, can you unmute yourself and?
Can you hear me?
Yeah, now we can hear you.
Achha, sorry. So I was just saying, I was just thanking Professor Fawad for inviting me to talk on such an important topic. It's a hard act to follow how Sohail presented the whole thing in such a short time. So I'll do my best and we'll see how we can help our colleagues. So the topic assigned to me was managing hypertension in special situations. And one second. Achha. So the second case that is sort of more aligned with my talk, I'm just going to present the case and then we'll discuss the case probably at the end. It's a 60-year-old smoker, diabetic and hypertensive patient who is complaining of left side weakness for about an hour. Came with a blood pressure of 190 by 110 on presentation. And probably this is something that we all face probably at least on a weekly basis in our ER. And we need to probably know how to manage this blood pressure. So these are the situations which we sort of term as special situation. And the term that is coined for this is hypertension in special situation, when hypertension is associated with another comorbid condition or a physiological condition. What are the special situations? We have diabetes, CKD, stroke, asthma, COPD, ischemic heart disease, heart failure, atrial fibrillation, and so on. So we're going to touch on the more common ones in our short talk. So as Sohail has already mentioned, once somebody is diagnosed with hypertension, we always give them lifestyle advice, and then based on their initial blood pressure readings and the blood pressure readings that we get after checking the blood pressure properly, just like Sohail elaborated, if the blood pressure is in the range of 140 to 160 systolic and 90 to 100 diastolic, we will probably try to use lifestyle modification, and then if they have other comorbid conditions which make them high risk like CKD, diabetes, we will try to start them on some form of medical therapy to reduce it. If they do not have any other high risk conditions, then we'll probably try lifestyle modification for about 3 to 6 months before we opt for medical therapy. If their blood pressure on presentation is more than 160 by 100, again checked correctly, then we should start them on medical therapy straight away. So there are two management options, obviously non-pharmacological and pharmacological. In terms of non-pharmacological options, we have obviously weight loss, DASH diet, sodium restriction, potassium supplementation, increased physical activity, and then reduction of alcohol or stimulant intake. Once we have done all that, and once we realize that this patient needs some form of medical therapy to help lower his or her blood pressure, then usually what we all do is we start on a dual combination therapy. The reason being that we know for a fact that about 85% of patients who are diagnosed with hypertension need at least 2 drugs to reduce their blood pressure. So usually what's recommended by the recent guidelines is that you start on a low dose, do a combination of 2 different tablets, and then in the third stage you will add possibly a diuretic to it, and in the fourth stage where you probably label them as resistant hypertension, which we are going to hear about more in the next talk, we add in spironolactones and other medical therapies. We have loads of tablets that we all know, so we're going to just go into the special situation business. So again, we know that beta blockers are sort of contraindicated, relatively contraindicated in patients with bad COPD or asthma. And then ACE and ARBs are some of the drug classes that we don't really like giving in pregnant patients. And then in other patients where we want some rate limiting mechanism along with antihypertensive action, we try using beta blocker or calcium channel blocker depending on their anatomy. So talking about hypertension with diabetes, I think this is the most commonly associated two pathologies that we see in our OPDs on daily basis. So if you look at these highlighted points, these are some of the points that not all of us realize. So in contrast to patients with type 2 diabetes, those with type 1 diabetes typically develop renal disease even before they develop hypertension. So these are the patients where you need to keep an eye on proteinuria, and you try to put them on an ACE or a low dose ARB ahead of time. And then in patients who have type 2 diabetes, they are more likely to develop hypertension than patients who do not have diabetes. So what it means in summary is that in somebody who has diabetes and who feel that they're not hypertensive, or whose blood pressure readings in your clinic are not coming up in the hypertensive range, probably they should be checked with a 24-hour blood pressure monitor to make sure they don't have any masked hypertension. So how do you control it? BP should be lowered if their blood pressure is more than 140 by 90 systolic, and the target is usually 130 by 80, unless they are elderly, in which you aim for 140 by 80. Treatment strategy should always include a renin-angiotensin system inhibitor and a calcium channel blocker, or sometimes a thiazide-like diuretic if they do not have proteinuria. Treatment should also include a statin for primary prevention. If they have complicated diabetes, that is with target organ damage, you try to reduce their LDL to 70, or try to bring it down to less than 100 if they do not have any complications of diabetes. So we have a vast body of evidence for use of ACEs and ARBs in diabetic population. One paper that probably is of interest to me, which was published recently, was about telmisartan, where they showed that they have other mechanisms other than lowering your blood pressure, by which it actually improves glucose tolerance and improves insulin resistance. Also, what we know for a fact is patients who have diabetes, they eventually are at a high risk of developing hypertension at some point in life because of renal arteriosclerosis. And what we have seen in one of the studies that was published in New England Journal of Medicine comparing telmisartan to a placebo is that these you can sort of reduce the development of diabetes in these hypertensive patients if we put them on telmisartan. So hypertension with CKD again is something that we face on daily basis. The whole mechanism with which both of these coexist, which comes before the other, is always something which is of more of a theoretical importance, because if CKD has caused hypertension or if hypertension has caused CKD, treatment essentially remains the same. If they have proteinuria, you start them on an ACE or ARB and along with a calcium channel blocker. If they do not have proteinuria, you can put them on ACE, ARB, a calcium channel blocker, and a thiazide-like diuretic right from the start. If you are unable to control it, then you can always add on a thiazide diuretic even with proteinuria. I know if they have advanced CKD numbers, a lot of us prefer beta blockers and alpha blockers rather than continuing to increase their ACE, ARBs, and diuretics because of obvious possibility of worsening of their renal function with these drugs. What we know is that a lower EGFR in these CKD patients is associated with resistant hypertension, masked hypertension, and elevated nighttime BP values. So in addition to probably trying to control their daytime readings, probably a 24-hour BP monitor is indicated in this population to make sure we are giving them the full benefit of the therapy and trying to improve the end outcomes in this patient population. Patients who have hypertension and also suffer from COPD, their blood pressure targets are pretty much the same. You start treating them if their systolic is more than 140 and diastolic is more than 90 to a target of 130 by 80. Lifestyle changes, probably top of the line is smoking cessation is mandatory. Environment pollution plays a role in it. And probably what we need to know is that, again, beta blockers can be given in selected population where COPD is probably not as advanced that they are requiring massive doses of every day. Probably mild COPD, you should be able to get away with using a beta blocker. Otherwise, an ACE or ARB along with a calcium channel blocker form the main basis of treatment for hypertension in this population. Patients with a previous stroke. So again, hypertension is probably the most important risk factor for ischemic or hemorrhagic stroke. And we can pretty much prevent a huge population from having this complication if we are able to manage their blood pressure adequately. And when I say adequately, one of the things that we look for in 24-hour blood pressure monitor in this population is their BP, blood pressure fluctuation. So even if their blood pressure average is coming to something acceptable for you, if you see those standard deviations and they are wide, probably they need some probably addition of a more longer acting blood pressure control medicine. And this is all based on evidence published in Lancet by our neurological colleagues. So you lower the blood pressure to less than 140/90. Mainstay of your treatment is again renin-angiotensin system blockers, calcium channel blockers, and diuretics or thiazide-like diuretics. Again, in this population, you need to lower their lipids as well as blood pressure to give them the full benefit and also to prevent any subsequent strokes. Again, with telmisartan, we have this data from 2008 where they who were not on this particular ARB. So again, it's something that we can keep in mind when we are treating this patient population. So hypertension with heart failure, again, something that we face on daily basis. Treating hypertension in this population has a major impact on reduction of heart failure hospitalization, and BP should be lowered if it's more than 140/90 and treated to a target of 120/70. They are all effective in, again, improving your clinical outcomes, but for probably calcium channel blockers, I would reserve my judgment for in acute cases and probably not great unless they have mildly reduced LV ejection fraction, and they are, you have sort of ran out of all other options for the blood pressure control. So patients with lipid disorders, so treatment criteria for them is the same. That you lower it once it's more than 140/90. Serum triglyceride lowering in this patient population is recommended in certain guidelines, especially if they're suffering from hypertension and diabetes. And what possible additional benefits that you get out of adding fenofibrates to this patient population is an increase in HDL and probably a reduction in their triglyceride levels. So coming to our case, this was a case. Should we discuss this now, or do you want to do it at the end?
I think we can keep it at the end after the third presentation.
Okay, so I will keep my slides till the end. Perfect, thank you.
Okay, thank you, Asaad. Just want you to stop sharing your slide. That's it. And we are ready for the third talk, and which is again a very important subject, that is resistant hypertension. But a number of times we label really, you can say, false diagnosis to the patient regarding resistant hypertension. So what's important? Let's see what Tayyab says about it. Yes, it's over to Tayyab.
Assalamu alaikum. Can everybody hear me?
Yes.
Asaad said it's a tough act to follow. I think it's a tough act following the two great Khans, you know. So I think without further delay, we'll start. I was already dozing off. So resistant hypertension diagnosis and treatment. So most of my talk, I think Sohail has already explained that the diagnosis is the key. How you diagnose and label somebody to be hypertensive. And that's very important in all of us when we are busy with our OPDs, whether it's a government or a public hospital, whether it's a private practice, that we need to make sure that we do check the blood pressure correctly. Patient is relaxed, the legs are not crossed, it's not pseudo hypertension, because that's where the key issue lies, especially in diagnosing the resistant hypertension. So let's see these slides. Okay, so resistant hypertension is defined as a seated office blood pressure of more than 140/90 in a patient treated with 3 or more antihypertensive medications and optimal or maximal tolerated dose. That includes a diuretic. The caveat is that you have to exclude pseudo resistance. That is, poor BP measurement technique, white coat effect, or non-adherence and suboptimal choices in antihypertensive therapy. So numbers are the same. It's just the amount of drugs have gone up. That is 3 agents, which includes a diuretic. And the main issue is that you need to exclude what Sohail described very well, that the blood pressure technique and the non-adherence and suboptimal choices needs to be excluded. Of course, secondary hypertension causes, which Asaad alluded to some of them, and then some drug-induced hypertension should be excluded also. So there are about 10%, it affects about 10% of hypertensive individuals. It varies in different countries, and this is from Western Hemisphere that we are looking at. I think in country like Pakistan, where patients sometimes don't tend to take blood pressure, they are very worried, and most of the patients would say, Dr. Saab, sari zindagi dawai khani hai, ya dawaiyan di miqdar kata diyo. So all of these, I think we are dealing with a whole lot more resistant hypertension, or in some cases, pseudo-resistant hypertension. So pseudo-resistant hypertension, as I said, could be caused by poor clinical blood pressure measurement technique and non-adherence to blood pressure medication, and white coat hypertension also. So for treatment of resistant hypertension, usually the NICE guidelines, which again, my colleagues described that most of us are following now, since ACC, AHA are kind of strict by 130 by 80 number, they say ACD, that's the number, that's the, abbreviation that you need to remember. A stands for ACE inhibitor, C is for calcium channel blocker, and D is for thiazide diuretic. Those are the 3 mainstay of drugs that you would add. And then you would add spironolactone to a patient who's still having high blood pressure if the potassium is less than 4.5 millimoles per liter. So these are the medications that you would consider when you see somebody and you have truly diagnosed with resistant hypertension. That would be chlorthalidone, that is a diuretic. You optimize your ACE-ARB combination with calcium channel blocker, as Dr. Asaad just told us, and then you add on a spironolactone. And if you still have issues, then you can consider combined alpha-beta blocker, which is labetalol, available in Pakistan, and then centrally acting alpha-2 agonist, which is clonidine. And finally, if it's an issue, then you can consider minoxidil and a loop diuretic. So again, another slide showing us the same thing. So you have now finally diagnosed somebody who has true resistant hypertension. This is not a pseudo hypertension. You have done an ambulatory monitoring on these patients. You have ensured that the patient is compliant with the medication. You have somehow the other done the pill counting or made sure the patient is taking medication. It's a true resistant hypertension case. Then these are the steps that you follow. So first step is that you optimize diuretics. Very easily available hydrochlorothiazide in Pakistan. It's available. It comes as a combination pill. You optimize that. Another ones are thiazide-like diuretic, that you have chlorthalidone. You do have metolazone available in Pakistan also with the name of Metanix. And then finally, if the patient's kidneys or GFR is low, it's a chronic kidney disease, then definitely consider loop diuretic. Second step, which in my opinion, before you go to resistant hypertension, you should have done that already, is that you optimize your combination pill, which is ACE with calcium channel, or mostly in Pakistan, we have ARB with calcium channel blocker. And as Asaad mentioned, that a lot of data comes out that if your blood pressure is more than 160 by 90, then you should just simply start with a combination pill at that point in time. Third and final would be adding a mineralogical MRA agent. That would be spironolactone or eplerenone. You have to be careful that the patients may have hyperkalemia, especially in CKD patients, or the patients who are already on ARB. And now recently with ARNI, we have seen considerable hyperkalemia when you add MRA with that. Now, breast tenderness, gynecomastia is again an issue less seen with eplerenone than aldactone. Again, this flow chart describes that condition. You have a patient which is resistant hypertension, which is on ACD, that is an ACE-ARB/calcium channel blocker diuretic. Next step would be to check a potassium. Potassium is less than 4.5, consider spironolactone. If the patient is intolerant, develops hyperkalemia or other issues, then you can consider eplerenone. Or you can consider switching them to a thiazide or loop diuretic. Now, if the potassium is high, then in that case, I think going to a thiazide-like diuretic would be a good choice. If still the patient's blood pressure is high, then consider an alpha blocker or an alpha and a beta blocker. As I mentioned, labetalol would be a good. And then we have a new agent. It's not a new agent. It's called moxonidine. I think Abbott markets it. That is available also. It's one of the newer blood pressure agents and only used in resistant hypertension. Again, same thing that we are, the few things that you should consider in these patients, other than switching those drugs, you can use fractional tablet dosing, that if the patient cannot tolerate a dose at one point, you can fractionate them. You can split the dose in the morning, in the afternoon, in the evening. Now, a lot of patients have difficulty using oral medication. Now, liquid forms are very difficult to get even in Pakistan, but the pharmacies can formulate those. There are pharmacies which can formulate. Some patients are very difficulty in ingesting the pills. Transdermal patch, again, in America, we used to have clonidine patches available, and a lot of patients we would give them. The only thing was that you have rebound hypertension. And then, of course, you can consider some off-label blood pressure medication to be used. Thank you very much.
Thank you, Tayyab, for nicely covering the topic within, I think, less than allocated time. Just if you can stop sharing your slide, then we'll come to the cases again. So just please.
Sure. I thought I will leave more time for my other learned colleagues.
Just waiting your slides to get off from the screen, and then we'll start discussion. Yeah, thank you very much. I think we are coming to the cases. And as Sohail covered the diagnosis and classification of hypertension, so I think I would allow him to discuss this first case. 48 years, smoker male, some dyslipidemia, blood pressure reading 146/92. So how to approach, Sohail, this kind of patient?
So 48 years old smoker, as you can see, he is currently asymptomatic, but his lipid panel is abnormal with total cholesterol of 215. And he is also a smoker, which is also a risk factor. And his blood pressure is 146/92. And if you go by International Society of Hypertension, it's kind of grade 2 hypertension, sorry, grade 1 hypertension. But if you go by ACC, staging, this is stage 2 hypertension. So definitely this patient has a diagnosis of hypertension, and it has been confirmed by multiple readings after having few increased blood pressure readings. So I hope that he has checked it at home. I hope that it has been validated. The other thing that Dr. Asaad, Akbar, Tayyab will attest to it, they have like a practice in the US, now they are in Pakistan. So just being a South Asian, and I also assume that this patient is also South Asian, it tends to underestimate the 10-year risk of cardiovascular disease. So by just putting these numbers, being a smoker, high lipid, cholesterol, and blood pressure is high, his calculated risk is about 11 to 12%, which kind of puts him into an intermediate risk. But being a South Asian, I would say he is intermediate to high risk. So based on these readings, I would definitely start this patient on some sort of antihypertensive medication, plus also non-pharmacological therapy as well. So this is what I would do in this case.
So I think you are considering the theoretical background for risk assessment, and then considering the borderline number that is 140/90 above in this particular patient. But if it's 10%, more than 10% risk, seriously, even 130/80 would be the cutoff. What about Asaad? How do you address such kind of situation?
I think makes perfect sense that, and I totally agree with Sohail, and I think in our last webinar as well, we sort of emphasized on this part that these 10-year scores are sort of underestimating the risk that we have for our Southeast Asian population. So yeah, I pretty much think that for these patients, early intervention is what you need, and probably early intervention. And I think what is needed in our population, and Sohail and Tayyab, and you will attest to it as well, that in our population, you need to probably spare 5 to 10 minutes of counseling every time they come to you. Like every 3 months or 6 months, the first question is, until how long do we need to continue these medications? And you need to start from the scratch. You need to start telling them all the risks that this blood pressure, high blood pressure is putting them at. And every time after about 15 or 20 minutes of talking to them, it seems like they're absorbing a bit of it. They'll agree to take these medicines, and then they'll come back after 3 months and we'll start again. So I think counseling, early intervention, and probably persistent counseling is something that you need in this sort of patient population.
Yes, again, and I personally have seen people in our setup usually don't follow your conservative measure that strictly. So it's important, always important when you have a borderline to high risk patient with even mildly increased blood pressure to start drugs straight away. And counseling is certainly very important. Yes, Tayyab, do you have to add anything?
No, I agree. I think if his, as you mentioned, if his ASCVD is 10%, he needs to be on a pill. And otherwise, also, I'll keep my threshold very low for this patient to be started on pharmacotherapy. Of course, you will counsel, as Asaad said, about DASH diet and exercise and decreased salt intake and everything else, weight loss. But at the end of the day, they'll end up being on the pill most likely, unless and until they drastically change their lifestyle.
Yeah. Even without symptoms, the patient should be on drugs with achieving target on every visit, and that he has or she has to take lifelong. Let's come to the second case. Yes, Asaad, I think you can narrate it and then further proceed it with what should be done.
So the second case is about a 60-year-old smoker, diabetic, hypertensive male who complained of left side weakness for about an hour. Comes to you, and the first blood pressure reading that you get is 190 by 110, and the question is, how do you manage this blood pressure? So again, thankfully we are helped by very clear guidelines on this. So I'm just going to share my slides, if we can. Hold on one second. So again, this patient is coming in, has all the risk factors for both a bleeding ischemic stroke as well as a hemorrhagic stroke. So obviously the first thing you do is obviously you start organizing for a CT brain or a CAT scan. But the question is, what do you do in the meantime? So the guidelines are pretty clear on this. And what we know is that if it's an intracranial hemorrhage, less than 6 hours from onset, and we know from the question that it's about an hour only, then if the blood pressure is systolic is between 150 to 220, you don't need to reduce it. If your systolic is more than 220, then you need to reduce the blood pressure with IV medication. If it's an ischemic stroke and it's less than 72 hours from CVA symptoms, which again it is, then you see if they qualify for IV thrombolytics. If they qualify, then you try to bring the blood pressure down to 185 by 110 before lytics. If they don't qualify, then you keep and if the blood pressure is less than 220 by 110, you don't need to reduce the blood pressure for 48 to 72 hours. So going back to our question, blood pressure is 190 by 110. So unless this blood pressure is going to qualify for thrombolytics, we don't really need to reduce the blood pressure. That's according to the guidelines. I don't know what everybody else thinks.
Yes, if anyone has to add anything more, Sohail, Tayyab.
Well, it is pretty obvious. Asaad just mentioned the guidelines, so it's hard for me to go against the guidelines. So that's what he said, and that's what we should do based on guidelines.
And it's a very important point, because what we have seen, even at pressures of like 170, 180, which is not really a high pressure for a patient with strokes, people are trying to reduce it down to 140 and 150, and how badly it affects that hypoperfuse area in the brain. So it's very clear that unless and until you have above 220 systolic, that's very important to understand. 220 systolic is the cut mark from where you have to address or treat your patient. Otherwise, you just have to wait and watch, unless and until, as Asaad mentioned, your patient is qualifying for IV thrombolysis. Then you have to bring it around 180 systolic and 110 diastolic. Let's come to the third case. 55 years, long-standing hypertensive female presenting complaint of increased blood pressure. Yes, Tayyab, it's up to you. Just go ahead and tell us.
So this is a female who's 55 and she's on 3 agents. She's on valsartan, she's on amlodipine, and then she's on atenolol 50 milligrams. So she's on, you would say, small to medium. She's on 25% dose of valsartan, which would be considered not an optimal dose. And then she's on 50% of amlodipine maximum dose and 50% of a beta blocker atenolol. Now, I've seen this question, hands raised. A lot of people are asking about beta blockers, and I would just kind of chime in here and to that they are not now considered as a first-line therapy with our current blood pressure regimen. We are still, so the main regimen is still the ACD that I mentioned, that NICE mentioned, ACCA mentioned. So a lot of people were asking about beta blockers while we were doing all these talks. So dealing with this patient, there are different ways you can deal with it. I think the first thing should be that you should optimize a valsartan and amlodipine combination, or consider doing an valsartan, amlodipine, and hydrochlorothiazide combination. I think at this point in time, if she's controlled on that, I would just take atenolol away, or if there's another indication to be on atenolol, if she has coronary artery disease or some other indication, she has migraine or some that she needs to be on beta blocker, then in that case, I would leave it alone. Otherwise, I will stay with valsartan, amlodipine, and hydrochlorothiazide combination, which we have in several brands and very easily, very economical available in Pakistan. That should be our way to go. And if still the patient's blood pressure is not controlled, then I would go to the other options, checking a potassium level, and then we can consider adding spironolactone, or we can consider labetalol, we can consider hydralazine, we can consider some other medication, minoxidil. But otherwise, I think she'll be just fine maximizing the dose of ARB, calcium channel blocker, and thiazide diuretic.
Thank you, Tayyab. And luckily, we have almost 10-15 minutes left. So let's recap again whatever we have discussed, starting from the classification and diagnosis. I think very commonly what we see in our setup, people are coming with just one reading, usually an ER visit, where they go for some symptoms, headache, ghabrahat, palpitation, unusual circumstances within family or something of that kind, even young male, female. And we see that ER doctor usually have given some captopril, furosemide, and sometimes even have started some antihypertensive as well. So Sohail, and I want all of your inputs as well in such kind of situation. A patient coming to you with follow-up 1 week back or 10 days back, had visited some ER or some primary care physician with antihypertensive treatment. Now what to do in such situation? Yes, Sohail.
Well, I guess your question is that if someone went somewhere and seen a doctor based on one reading, they have started them on antihypertensive medication. Again, it depends on if what the patient is, presenting with. If his blood pressure on his previous visit was more than 160 systolic, in that case, now if the patient is coming back, the blood pressure is controlled, I would not stop it. But say, for example, the patient went to the other doctor and the blood pressure was kind of borderline in early 140s or late 130s, and then he was started on antihypertensive medication without any non-pharmacological, therapy. In that case, I would hold that medication for a couple of weeks and check his blood pressure. I would also counsel him to check his blood pressure at home before I label him as someone with hypertension and commit him to lifelong oral antihypertensive therapy. So again, there are many factors. Blood pressure is kind of so fluent, and it gives you 10 different readings if you check it 10 times a day. And that is also something that I've seen with the patients. Sometimes they get over aggressive with that. So we have to properly counsel them how to check it at home, educate them on it. And again, I have that holistic approach to it.
Yes, certainly, just one reading with additional symptoms are really not enough to diagnose someone as hypertension. And I personally say even my students and juniors always first diagnose, try to get out some etiology, comorbidities, and complications. You have to judge your patient comprehensively before deciding about the treatment and management strategy. If Asaad or Tayyab want to add something.
Yeah, I agree. It has to be a holistic approach. You have to see what sort of a patient is sitting in front of you. If it's like a 20-year-old female who came in with a panic attack and a blood pressure of 140/90 and somebody puts them on something, that's totally not justified. Versus like if it's a 60-year-old diabetic patient has CKD, and they are kind of in denial that they have blood pressure, and they come to you and tell you that, oh, I had this one blood pressure reading, then you have to really go into the history, and then it will slowly come out that, oh yeah, it was high 2 years ago as well, and then it's high occasionally as well. So I think it's a holistic approach. You need to see what's sitting in front of you, and you need to probably churn out a bit of history depending on the risk factors that they have.
Thanks. Tayyab, do you want to add something?
Yes, I agree. You know, I think everybody has kind of emphasized and rehashed all those points. I think the key in our situation in Pakistan setup is number one, that we need to get the diagnosis correct. I think that is the key. I think managing is very easy. We have so many combination pills which are very relatively economical available. So I think diagnosing it correctly, excluding all those things as Sohail mentioned in his talks. And then another thing would be the counseling, that you just need to emphasize that this is a chronic disease. The pills are not cure, they are maintenance. So it's just like when we have 3 meals in a day, it's, you know, there's a certain amount of food everybody consumes every day. So it's for our maintenance. So this is not something that this pill is going to cure. And it's the same issue you get with all these chronic disease. You know, patient's LDL goes down and next thing patient stops the pill. They say, you know, मेरा cholesterol खत्म हो गया, मेरे weakness हो गई है, मेरी body कमजोर हो गई है. So same thing goes with hypertension also. You know, the for next day that's a BP ठीक हो गया सी. So मैं ये कहना जी आज आपने नाश्ता किया था, हाँ जी किया, दोपहर का खाया जी, हाँ जी खाया था, मैंने जी कल भी खाया था, कल भी खाया था. So I think we need to emphasize this a lot. Where I'm working, we have a big neurological unit here, and I see so many intracranial bleeds here that your heart just breaks. These young patients showing up with intracranial bleed just because they stop taking pills or went to get a thumb or something. I'm working in a private sector with a very affluent area of Lahore that I'm working at. So compliance and emphasis, taking medication is very important.
And even checking blood pressure for sake of like maintenance. Usually in our setup, people check their blood pressure while they're having symptoms. I usually give them this advice, बराए मेहरबानी कभी सर दर्द के अलावा भी बीपी चेक करके देख लिया करेंगे ठीक चल रहा है या नहीं चल रहा है. So for sake of your maintenance, you have to check your blood pressure while you are without symptoms, relaxed state. It's come to us a special situation. Usually we don't really dig out the compelling and contraindication in our patient of hypertension, usually at primary care level. It's just a number game treating patient. And a lot of myths about CKD patient, our primary care physician and a lot of general physicians, they stop ACE-ARB. Once they see slightly increased creatinine, I'm amazed without seeing potassium, what's the status? So your take on that, just counsel all of us who are...
100 totally agree with it, but I'll go even a step further. Not only will this stop the ACE-ARB or ARB, they'll also tell the patient that it's because of the medicine which they started that your kidneys are failing. So the patient and his entire family is going to be sitting in your clinic the next day. And that is one of the dilemmas of practicing here. कि यहाँ पे वो follow up नहीं है, बड़ा मुश्किल काम है. कि if you tell somebody, अभी day before yesterday I saw somebody who I had seen in 2019, and I put them on an ACE and ARB or ACE or something like that, and then they showed up in my clinic in 2022 after 3 years, and they said now the creatinine is 1.6. It was 1.1 or something then. And even in my note, when I started them on ARB, I said to recheck your creatinine in 2 weeks and come back to me. And they came back after 2 years. And again, patient compliance is an issue, but probably we need to maybe do a session on the fact that once you start somebody, ACE, ARB, or especially now with all this high heart failure therapies, that if slight increase in creatinine is seen after starting these empagliflozins and ACE, ARBs and aldactones, you don't just stop these medicines. These medicines are life-saving medicines for these patients. So you need to sort of bear it out a bit. You need maybe calm down the patient, ask them to repeat the bloods in another 2 weeks or so. And if they are holding up, that's where you stop. Like you don't stop the medicines just every time the creatinine goes from 1.1 to 1.2. That means nothing, because you will always have a slight increase in creatinine once you start high dose of these medicines.
And important is for such kind of patient is potassium that we have to check for. And other way around, I have seen a lot of junior doctors starting this MRA with ACE-ARB, good doses of ACE-ARB and without checking potassium, without knowing even baseline potassium. That is also very important when you are adding, as Tayyab mentioned, for resistant hypertension or for post-MI heart failure patient, eplerenone or spironolactone. Potassium is very important. I've seen life-threatening arrhythmias, patient coming with severe raised potassiums, not that much raised creatinine because of an imbalance of that drug in them. Second, Asad, I think we should say something about pregnancy and hypertension. When to treat, what drugs, and what should be the stepwise fashion? What if slightly increase? There are a lot of questions in here.
I know this always comes up. First of all, I'm a bit liberal. I don't treat their blood pressures to 120/80s because they have obviously got fluid retention in them as well. So you don't go for 120/80s, maybe 135, 140 is maybe acceptable, especially because they're young females. They don't really have any other risk factors. Secondly, in terms of options that we have, I think labetalol, Eldomet, these are safer options. We know calcium channel blockers and ACE ARBs are probably out. Diuretics probably you shouldn't give. And then labetalol and Eldomet, probably I stick between the two. And then labetalol, you can keep going up with the dose. So I feel pretty safe with using labetalol in them.
So it's I think nifedipine. What are your thoughts on nifedipine? It can be if it's very high, not controlling on methyl.
People use it, and I've seen it used. And I think the only reason we shy away from this is because of paucity of data. There's really not much data with labetalol either. But because people have used it, and it's sort of a level of evidence C, people are using it, so we are all using it. And I think if you have developed a confidence level with nifedipine, probably you're okay to use it. But I sort of stick with labetalol. Probably that's just my personal preference.
Although you have given a nice algorithm regarding optimizing treatment, adding on MRAs as well, if someone is not controlling on anything, 180, 190, you have seen some very special cases. You have optimized drug up to every levels, and they are still coming with 180, 190 systolic and 100, 110 diastolic. What's your approach to those kind of resistant hypertensives?
So one thing that we kind of have skipped in between is that those patients, you should do some form of a secondary hypertension workup, meaning like you look for renal artery stenosis, you look for PO, you check a serum aldosterone level, serum renin level on these, or it's a coarctation of AO type. It's a young patient. So those things, I thought like they are not truly resistant hypertensives, but we should look for secondary causes of hypertension with that. Now, there are some interventional therapies that are out there that not have panned out yet. All of us know about renal denervation therapy. We have 3 simplicity trials out there, but none of them was really conclusive trial. And we had these patients come in, and these are very simple procedures for us to do peripheral work. So Sohail does quite a bit of work. It's a very simple procedure to be done, but didn't pan out. Then there are certain other procedures where you can make a shunt between an artery and vein and decrease the systemic pressure also. Those procedures have been described also in these patients. But at that point in time, if the patient is on 6 agents and it's still not controlled at that point, then I do get help from my nephrology colleagues also. And I start picking up on their brains also. Hey, is there anything that I'm missing that you think, instead of just adding up? And then there are a few things that you can do just to make sure that you go back to your basics. That is, if the compliance is an issue. Now, pill counting becomes very difficult. Now, you know how they treated TB in Pakistan, directly observe, treat, that you make sure that you tell the family member, hey, make sure that they take the drug. You can check the urine levels also, but again, very difficult in a country like Pakistan. But I think compliance is a big issue in these patients. I'll be hard to believe the patient is on valsartan 320, nifedipine 60 milligrams, if you can get an Adalet, and then your hydrochlorothiazide 25 milligrams, and you have hydralazine, and you have a labetalol ongoing, that you would be not able to control. Most of these patients that I have seen in a clinical practice are essentially chronic kidney disease patients. They are not up to date on their dialysis schedule. Those are the ones that I have seen that they come in a day before their dialysis with a BP of 200 and 220. And I'll tell you, you bring their BP down to 130, 140, they're totally down. They're drained out of their energy. They're so used to living at 160, 170. But these are the patients, yes, I have seen in my clinics that have been very difficult, and we have a big renal transplant program here, and their nephrologist sends it to me. These anti-rejection drugs that they take, these cyclosporines and other drugs, they are a cause of secondary hypertension. A lot of patients are taking licorice. A lot of patients are taking NSAIDs. Some girls are taking oral contraceptive pill. So you start thinking about these things and you start probing them into the history. Seldom you will find somebody who has this primary hypertension with no secondary cause and good compliance. In that case, I usually send them to a good renal colleague, and both of us put our heads together to find a way out.
Very nice. Usually it's almost, yeah. Sohail, do you want to add something?
Yeah, there is one very comment that I was just reading by Shazia Mohsen, that she is a pediatric cardiologist, and she also talked about the social taboo regarding taking antihypertensive medication in some social circles. I kind of agree with her in the sense that when I joined NICVD in August, I've never seen a place in the world where you do 35 to 40 ST elevation MI per day. I mean, this is crazy. I mean, while we were in the US, you get 3 or 4 STEMI a day. It's a very busy day. And then I'm seeing patients like who are 25-year-old, 30-year-old with major heart attacks. The other day, I had a lady, she was 20 years old with a proximal LED lesion. So when we talk about education, I think the education, we don't have to wait till it's too late. When the patients are in their 30s, they already have a heart attack, and then we talk about how to prevent it. I think the prevention talk should start in schools, in very early schools. I mean, it should be part of the curriculum. The kids should be taught what the healthy lifestyle should look like, what the healthy diet is. And this should start very early, not only in schools, but also at homes. So this is a point that we need to emphasize. We need to get this message across. And here we talk about other diseases, for example, cancer, and which is okay. But if you look at what is the #1 cause of death in this country, it still remains the heart disease. I think we need to be very proactive. We need to have a proper social campaign, not only it should start from us, but we should also involve our community to get this word across. So this is just the point that Shazia Mohsen raised is very valid, and we should definitely look into it.
Thank you, Sohail. I think we can speak volumes on hypertension. That's a subject very common, very complicated, not easy. Every individual is different. So main objective is to assess your patient properly, diagnose properly, get out the etiology, complication, associated comorbid, to finally decide exact management strategy for patient, even a lot of variability. So understand your patient's behavior, his lifestyle, everything. And then we can come to a clear management strategy, what really suits him. So with that, it's almost ended. And we will plan, inshallah, public awareness sessions as well. This is a pure academic tips session for our junior colleagues regarding, although we have covered dyslipidemia, hypertension, we'll come to complex cardiology subject as well. And we'll go to public awareness sessions through my page and other medium as well, covering your thoughts about propagating knowledge of, and I think key is prevention. We can't manage patients by putting stents. It's all controlling the risk factors. With that, if you have any final comment to say, Asaad, Sohail, Tayyab, any final last liner?
Yeah, I think counseling and probably seeing the patient as a whole, and also taking a holistic approach regarding statins and everything else that we discussed is something that should be the key point for everybody who listen to the webinar.
Yes, Tayyab, do you want to say anything?
I think we covered everything. Thank you very much. It was wonderful.
So I thank all my friends, colleagues who participated as a speaker. I thank the participant who were there for last 1 hour. And lastly, I thank the Hainoon and Ammar for all his effort in which he contributed in executing this webinar. Thanks all.
Thank you, sir.
Thank you.